How's it going, everyone? Today we'll be talking about the effects of blood volume on stroke volume and cardiac output. And we'll introduce the terms preload and afterload and how they affect the amount of blood that's being ejected from the heart. Before we talk about the details of preload and afterload, let's review the movement of blood in and out of the heart. Keep in mind that we're going to have a lecture this week about the phases of the cardiac cycle, so I'll be brushing up on some terms that you maybe haven't heard in a while or just haven't heard at all. So keep in mind that when venous blood from the peripheral circulation makes its way back to the heart, it's going to enter through the superior and inferior vena cava, and it's going to fill up the right atrium with this deoxygenated blood. At the same time, blood that is returning from the pulmonary circulation from the lungs, that oxygenated blood is also filling up the left atrium. And so the atrium at the same time are going to fill up with blood. And then what's going to happen is that these valves that separate the atrium and the ventricles, called atrioventricular valves, respectively, this is the tricuspid valve, and this is the bicuspid valve. These valves are going to open, and then that blood that was inside each atrium is going to make its way down into the ventricles. So sorry, I know I'm not the best artist with the tools that I have, but that blood, again, is entering the ventricles. And now as the ventricles fill up with blood, right, so these ventricles are filling up with blood, what that's going to do is it's going to stretch out these cardiac muscle cells, these cardiac myocytes. And that's really the basis of what we're going to talk about today, which is the stretch of these cardiac myocytes called preload. And then what's going to happen is that the electrical activity of the heart is going to make its way down to the ventricles. And these cardiac myocytes that surround the ventricles are going to contract. And that's going to force pressure to build up inside the right ventricle and the left ventricle. And then when the pressure on the inside of the ventricles exceeds the pressure on the outside of the valves here, the pulmonary valve, and then the aortic valve, what's going to happen is then blood is ejected from the ventricle into those great vessels. So we're seeing the blood from the right ventricle leave and enter the pulmonary trunk. The blood from the left ventricle is ejected and makes its way into the aorta. And so the heart is going to eject a certain amount of blood that fills up these ventricles, and that's called ejection fraction. So now keep in mind, we are going to talk about a lot of terms that have to deal with volume and pressure within the heart. And a lot of times when we talk about these different variables, we are referring to the left side of the heart. The reason being is because this is the blood, the oxygenated blood that's getting out to the rest of the body. So really when we talk about these terms like stroke volume and ejection fraction, both the left ventricle and the right ventricle have an ejection fraction, have an output, have a stroke volume, but we are mainly concerned with the work and output from the left side, the left ventricle. The variable used to describe the output of the heart is called cardiac output, and this is the liter of blood per minute that this left ventricle is going to eject. You may remember that the formula for cardiac output is heart rate times stroke volume. And today we are mostly going to be talking about the different volumes filling up the heart and then the volume of blood being ejected from the heart. So the amount of blood ejected from the left ventricle on every beat is called stroke volume. And so that's the amount of blood that's going to leave that left ventricle and then be delivered to the rest of the body. And stroke volume is going to be dictated by a variable called end diastolic volume. And that is going to be the volume of blood that fills this left ventricle at the end of diastole, or the resting period for the ventricles. So again, that blood from the atria is going to enter the left ventricle. Once this atrioventricular valve opens, the the left ventricle will fill up with blood. That's going to cause stretching of these cardiac myocytes, and then those myocytes will contract in order to eject blood. And as we're going to see today, the more we fill up the left ventricle with blood, the preload, the more we are going to be ejecting out of the heart. So we're going to see an increase in stroke volume and an increase in cardiac output. So again, the cardiac muscle has to develop enough force in order to eject out an appropriate amount of stroke volume and cardiac output every single minute. Now, what do I mean when I say appropriate? That means ideal for the given conditions. So for example, as you sit here and watch this video, there's not a high metabolic demand, so cardiac output is a little bit lower, and your heart produces your cardiac muscle produces just enough force in order to drive enough stroke volume for this activity. However, if you started to go on a run, that metabolic demand would increase, and therefore the amount of blood that needs to be ejected out of the heart, stroke volume and cardiac output, every single minute will increase as well. And so then the heart has to produce more force out of that cardiac muscle in order to get the amount of blood and oxygen needed across the body. Blood is going to create a pressure in the walls of our heart and our blood vessels. Again, that's called blood pressure. And the higher amount of blood volume that enters the heart is going to equal higher pressures. And also, that increase in volume is going to affect our cardiac muscle. Like we said earlier, the higher amount of volume that fills the left ventricle during its resting period, called diastole, is going to influence the length of those cardiac muscles. So those sarcomeres, as we fill up that left ventricle with blood during diastole, those ventricles and those sarcomeres on those cardiac muscle fibers are going to lengthen and they're going to stretch. And we'll talk a little bit more about those effects on stroke volume, but as we said, that's going to help increase stroke volume and the amount being ejected from the left side. However, the ejection of blood from the heart is not only dictated by the amount of blood that fills the left ventricle, but it's also determined by the amount of pressure or volume of blood that the heart must work against. And so for the left ventricle, the pressures inside of the left ventricle have to exceed the pressures on the outside or of the arterial blood. And that is referred to as afterload. And so, as we'll talk about today, both preload and afterload are going to influence the amount of blood ejected from the left ventricle, again known as stroke volume, and that therefore impacts cardiac output. So let's get to the question of why preload impacts stroke volume and cardiac output. And the reason lies within our muscle mechanics. So you may remember from your physiology course that the length of a sarcomere and the length of a fiber will ultimately dictate the tension produced by that fiber, and that's going to translate into force. So in this figure here, to the right, you could see the relationship between length and tension in skeletal muscle, which is these lines to the outside, and then the lines on the inside here describes that relationship within cardiac muscle. So let's focus on that one. And so what you could see is as the cardiac sarcomeres lengthen, it is going to hit an optimal length where it can produce peak tension. And so anything then beyond that point, the tension that can be produced by that fiber will decrease. And so this is the relationship between length and tension within the cardiac muscle fibers. So why is the length of the cardiac muscle fiber ultimately going to determine the tension and force produced by the cardiac muscle? And then how is that going to impact stroke volume and cardiac output? Well, remember from probably previous physiology courses that cardiac muscle and skeletal muscle, the amount of tension that those fibers can produce is going to be based upon the amount of myosin and actin interactions. So as these sarcomeres lengthen, what you're going to see is that there are more myosin-actin interactions that can occur. And then we're going to hit a certain point, this optimal length, where we could get maximal force development through these interactions of myosin and actin. And then anything past that point, we're not going to have as many interactions, so therefore you see the tension produced by those fibers decrease. And so how does this apply to cardiac output and stroke volume? Well, this mechanism is called the Frank-Starling mechanism. So as the amount of blood entering the left ventricle increases, the preload increases. And so these fibers will become longer, and then therefore when they are activated, when they contract, they're going to be able to produce higher tensions and produce more force. And so then what ultimately happens is that, that preload affects, determines the length of the sarcomeres, and that's going to influence the strength of contraction. And so as we increase preload and we increase end diastolic volume, we're going to get an increase in stroke volume produced by the left ventricle, and therefore we're going to get an increase in cardiac output. It's important to note that muscle fibers will produce tension both passively and actively. Passive tension comes from the elastic components of fibers, and as sarcomere length and fiber length increases, so does the amount of passive tension. However, active tension is going to be brought about by these cross bridges between myosin and actin. And as we just discussed, as fiber length and sarcomere length increases, there can be more and more cross bridges that are formed until we hit this optimal length. It's important to note that preload is helping to increase this passive tension, but it's also helping to optimize the amount of interactions between myosin and actin when the electrical activity of the heart will activate these cardiac muscle fibers. Typically, we will not see the heart work on this descending portion of the curve because in a healthy heart, we are going to be restricted from going to the sarcomere lengths and these fiber lengths beyond the optimal length. So therefore, the cardiac muscle will be efficient in ejecting out blood and producing the proper amount of force to keep up with stroke volume and cardiac output. So these length-tension relationships are ultimately going to be the basis for the Frank-Starling mechanism, the Frank-Starling Law of the heart. You can see that at a given end diastolic volume at rest, we are going to produce a certain stroke volume. So here, for every 135 milliliters of end diastolic volume, we produce a stroke volume of 70. But as we increase the preload to the left ventricle, as we increase the end diastolic volume of the left ventricle, we are also going to increase stroke volume, and that is going to increase cardiac output. So to review, the fundamental concept of the Frank-Starling mechanism of the heart is that an increase in preload or an increase in end diastolic volume will lead to greater stroke volumes and greater cardiac outputs because of the stretch of the sarcomere, which leads to more optimal overlap for myosin and actin, that can create more cross bridges when that cardiac muscle cell is activated. Just one more thing about this relationship, just keeping in mind comparing cardiac muscle and skeletal muscle, that cardiac muscle will not have the same range of sarcomere lengths as compared to skeletal muscle, but also keeping in mind, again, that the heart is limited in the amount of length that can be experienced by its fibers, especially due to the pericardium. That stretch experienced by the heart is limited, so we don't typically see the lengths that would bring us on the descending portion of this curve. But again, keeping in mind that preload increases those sarcomere lengths, and as physiological sarcomere length in the heart will increase. So does the tension, force produced by those heart muscles, and therefore the stroke volume will increase. So keep in mind going forward that if we want to increase the stroke volume and the cardiac output produced by the heart by increasing venous return to the heart, to this right atrium, ultimately what that's going to translate to is to higher preload and higher end diastolic volume. And by doing that, we can increase the stroke volume of the left ventricle. In addition to preload, ultimately afterload is going to determine the amount of stroke volume that is ejected from the ventricles. So again, focusing on the left side, we know that in order for this valve to open, in order for this aortic valve to open, the pressure within the left ventricle has to exceed the pressure on the other side of the valve in the aorta. So ultimately, the arterial blood pressure, the blood pressure on this arterial side, is going to dictate the amount of stroke volume ejected from the left side of the heart. Because if pressure in the aorta is higher, well, then the pressure on the inside of the left ventricle also has to be higher for blood to be ejected out. And this is going to limit the amount of blood and the time that the left ventricle has to eject blood out to the rest of the body. And so this, again, this concept is called afterload. Afterload is going to be the resistance to ventricular ejection. Aortic pressure is what the left ventricle must overcome in order to open up the aortic valve and eject out blood. So if there is an increase in the amount of blood or the amount of pressure on that arterial side, it's going to limit and decrease stroke volume and cardiac output. Ultimately, an increase in arterial pressure or aortic pressure, an increase in afterload, is going to lead to a decrease in the shortening velocity of that cardiac muscle. And that's going to lead to a decrease in the rate of ejection from that ventricle. And ultimately, what that's going to lead is more blood left over within that left ventricle. So stroke volume will decrease. So looking at it on the heart, if our aortic pressure increases, if our afterload increases, that's going to lead to a decreased velocity of shortening for this cardiac muscle. It's going to lead to less blood being ejected out of that left ventricle and more blood that is left over after contraction. And so that volume of blood left over after contraction is called end-systolic volume, the volume of blood in the left ventricle after systole. So what we see is that for a given amount of preload, or for a given left ventricular end diastolic pressure or end diastolic volume, which we talked about, an increase in afterload is going to decrease stroke volume because, again, the heart has to work against this higher pressure and is not going to be able to eject out much blood. This occurs when resistance on the arterial side increases, and therefore the pressure of the arterial blood is also going to increase. However, this relationship works inversely. So if we're able to decrease vascular resistance and we're able to decrease pressure on the arterial side, well, then that is going to increase stroke volume due to this drop in afterload. To summarize all that we learned today, if we increase venous return to the heart, if we increase the amount of blood that fills the ventricles, known as end diastolic volume, by increasing preload, that is going to lead to more optimal sarcomere lengths and increased stroke volume and cardiac output. However, it works in the opposite manner as well. If we decrease venous return, if we decrease preload, then that will decrease stroke volume and cardiac output. Stroke volume and cardiac output are also impacted by arterial or aortic pressure as well. If that aortic pressure increases, that's going to decrease the velocity of shortening and therefore decrease also the stroke volume and cardiac output produced by the left ventricle. However, if there is a decrease in afterload, there will be an increase in stroke volume and cardiac output. Today we learned about how blood volumes can impact the mechanics and the output of our cardiac muscle. Throughout the semester, we're going to see how our body adjusts these blood volumes in order to carry out normal function, in order to keep up stroke volume and cardiac output. But again, the main takeaway today is that the amount of arterial blood and the amount of venous blood returning back to the heart can ultimately influence the output produced by the cardiac muscle. This week, we'll be talking a little bit more about the heart itself and the cardiac cycle and the electrical activity of the heart. But thank you guys so much for watching this video today, and I will see you in our next lecture.